Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hi, this is Dr. Nick Biasotto. I am the host of MSD's podcast, Delaware Healthcare Reality. And today my discussion will be on prior authorizations, a very controversial issue in medicine today. There will be no guests because this will be on my watch only here. Prior authorizations, where do I begin? Let's start with control. In the 1960s, it was beginning to be realized that the cost of medical care in the United States was rising at a rate that over time could be unsustainable. With this in the crosshairs, it would be the time to place limitations on medical spending, especially at the hospital level. So CMS, the Center for Medical Services, sought to pass Medicare and Medicaid legislation to address this issue. Those of us familiar with this legislation began to see this control with the advent of utilization review. This was a process designed to stem the tide of unnecessary hospitalizations and/or prolonged hospital stays. For example, a doctor who wished to perform a procedure or justify an admission would have his case reviewed for its need to be done in hospital. If it didn't meet certain criteria, the admission or procedure could be denied. This meant that the admitting physician and hospital could be denied reimbursement if the patient did not qualify to be admitted. This process over time transformed into today's prior authorizations as a way to decrease the cost of medical testing, whether those authorizations were for imaging studies such as MRIs, CT scans, ultrasounds, medications, medical equipment, or outpatient therapy. More controls were legislatively justified as the cost of medical care continued to rise. Yet the overall health of Americans declined, despite the fact that America has the best medical schools, the best research centers, the best hospitals, the best medical diagnostic equipment, and the best doctors. As to why this is happening, I will discuss this later in the podcast. As American healthcare outcomes are poorer than many other developed countries, we perform poorly in life expectancy, infant mortality, diabetes, obesity, heart disease, etc. The cost of care continues to rise. And now, the present prior authorization issues. While payers, the insurance companies including Medicare, tout the need to control prior authorizations, physicians see these programs as time-consuming, overly burdensome, and potentially a barrier to appropriate and timely patient care. Also, the process is one reason the physician burnout is further threatening our healthcare system. The cost of continuing the present prior authorization system is both arduous to the doctor and I'm sure the payer system, and this is a problem. This has led many physicians to retire early, join a hospital system, work their hospital work week and have the hospitals deal with prior authorizations, or change to another system of medicine such as concierge medicine. In 1980s, when I was practicing, it was rather simple. You billed what you billed, you usually got paid for. You didn't have to beg anyone to give us permission to order a test, and things flowed smoothly. The cost of running your practice wasn't as expensive as it is today, and so it was an easier way for doctors to remain solo practitioners and see their patients in that manner. So let's talk statistics, particularly speaking to the AMA's 2022 prior authorization survey, where 94% of patients reported delays in care, and many patients have waited days, 3 on the average, to have a test approved, or many have waited longer for medication approvals, usually because the desired medication was not on the insurance company's formulary, which, by the way, may change yearly. This seems to be a concern. Why? 80% of patients give up the process and abandon their treatment. 33% of physicians report that the process has led to a serious adverse event. 25% of physicians have said that prior authorizations delays have led to hospitalizations that may have been unnecessary. And 19% of physicians have reported that prior authorization delays have led to life-threatening events. and 9% have stated that prior authorizations have led to a patient's disability. Wow, that is alarming. For many years, since I was president of the Medical Society in 2008 and 2010, I have asked for a bit of transparency from the payers. That is, does the process lead to better patient outcomes? Does it save lives? Or has it reduced the cost of care? Does it save money? I've yet to receive an answer, although I chair the third-party payer committee dealing with payer-doctor issues with frequent meetings with the CEOs or their representatives trying to discuss issues between doctors and payers, and this is always a hot topic. Prior authorizations is also estimated to cost the system with physician staff time and payer staff time in excess of $100 million a year. Wow. Couldn't we use this money more effectively? What's funny, to justify the prior authorization system, payers have said they make their decisions on evidence-based guidelines from medical specialty societies. Yet 31% of physicians say decisions are rarely or never evidence-based. Physicians report that their offices go through the prior authorization process 40 times a week, spend 2 working days completing a prior authorization, and some even hire staff specifically to address prior authorization issues. The last statistic, 89% of physicians report that prior authorizations interfere with the continuity of care, i.e. misprescription medication doses can interrupt chronic patient treatments. Let me give you an example of a typical prior authorization denial. Mrs. Jones needs an MRI of the brain for a suspected lesion. If the correct boxes in the payer inquiry are not checked, it may be denied. The staff struggles to get an approval. Day 1 may pass, day 2 may pass, and physicians finally say, I would like to have a peer-to-peer review. That is, the doctor talks to a specialist in his specialty to gain access or to gain approval for those tests. And 98% of the time, they get approved. The reviewing physician approves the request without a problem, and 2 days or more have been wasted trying to get it. So what is to become of the prior authorization system? The AMA, the AOA continuously work to streamline the process, yet it still remains a burdensome one. My very personal belief is this process should be abandoned. So now how do we contain cost in the medical world? Who is in control? The doctor-patient relationship is a sacred one, and the decisions regarding the help needed should be theirs and theirs alone, to a degree. Therefore, let's end on control, or lack thereof. We still have the best medical capabilities in the United States. We still have poor outcomes. Why? Let's think about it. America has become an overindulgent nation. We eat too much, we drink to excess, we indulge in illicit drugs, we smoke too much, we eat the wrong foods, we have access to fast food, as we are a fast society, and on every street corner, and you can find a liquor store right by closely, and vape stores are right around the corner. Obesity has become one of the most cost drivers in our nation's poor outcome and high costs of care, because this condition, affecting roughly 40 to 45% of the United States population, adversely affects every body system. It can lead to diabetes, liver failure, hypertension, hyperlipidemia, heart disease, and kidney disease. And recent studies have shown there may be an increase in chances of getting certain cancers, breast and colon in particular. Until Americans decide to change their lifestyle and assume a healthier road, I believe the cost of care will continue to rise and our outcomes will remain the same. This podcast is a tee-up to our next podcast dealing with obesity with our guest, Dr. Shalini Shaw, a family physician with a special interest in treatment of obesity. Stay tuned. Lastly, I would like to credit Lynn Robinson of our Physician Relations Department in assisting me with research on this issue. But fresh off the press, roughly about 2 weeks ago, CMS has been meeting with the AMA, and then they have come up with some new rules for prior authorization reforms. They released their final rule making important reforms to prior authorizations to cut care delays and electronically stream the process for physicians. Together, the changes will save physicians an estimated $15 billion over 10 years, according to the U.S. Department of Health and Human Services. The rule addresses prior authorizations for medical services in these governmental regulated health plans: Medicare Advantage, State Medicaid and Children's Health Insurance Program, or CHIP, Medicaid Managed Care Plans and CHIP Managed Care Plans, and qualified health plan insurers on the federally facilitated exchanges. But as Medicare goes, usually commercial insurances also go. The rule, quote, requires impacted plans to support an electronic prior authorization process that is embedded within the physician's electronic medical records, bringing the much-needed automation and efficiency to the current time-consuming manual workflow. Moreover, the administration's action will, quote, significantly enhance transparency around prior authorizations by requiring specific denial reasons and public reporting of program metrics, as well as requiring that prior authorization information be available to patients to help them become more informed decision makers, end of quote. Enforcement of these policies include CMS sanctions and civil monetary penalties. Starting in 2026, affected payers will have to send prior authorization decisions within 72 hours of urgent requests and within a week for non-urgent requests. The AMA strongly advocated faster time frames, i.e. 24 hours for urgent requests and 48 hours for standard ones. CMS said it will consider updating these policies in future rulemaking. One question I have about this is, who is going to pay for the software needed for our electronic medical records to be able to perform these functions? That is still a question unanswered. This is Dr. Nick Biasotto talking about prior authorizations.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. Delaware Healthcare Reality is produced by Tom Mitten. I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.